So first of all, I welcome you all to this conference. It is, I think, for the first time that the midterm is being organized, a national level conference in this part of the country. Earlier, long back in the days of Dr. Daljeet Singh, there was an AIOS conference held in this Amritsar. So this talk is basically targeted towards general ophthalmologists, but here I see they are more of oculoplastics and pediatric ophthalmologists, and they know more of what I am trying to convince the general ophthalmologists, because there are few myths amongst the general ophthalmologists for the reasons they do not either refer in time, or they misguide the patient, or they would sometimes incorporate such disbeliefs in the patients that the patient becomes very fearful of getting the ptosis surgeries done even at a later stage. So I'll try to address them one by one. We all know what ptosis is, about the drooping of the lid, one or both. It could be congenital or acquired. This is simple congenital ptosis, and an LPS resection can give you a good result. Can I have a pointer if possible? Pointer. If we have a poor LPS section, then we go in for a sling surgery. So the first myth what I'm going to address is the age of the patient. Most of the doctors, even our colleagues, think that ptosis cannot be operated at a very early or a very late age. So this is very common problem that we encounter when a young person comes and we ask them why you didn't get a surgery done. He or she would have been told by some very prominent names in the city that don't get it touched even before the age of 15 or 18. So that is something which is wrong, and it is a wrong information, I would say. The fact is, an ideal age for ptosis correction is preschool going age, like this chap, but even we can operate at an earlier age if the risk of amblyopia is more and the pupil is covered. Like is then in this girl, she was about 1.5 years of age when she was brought to me. Now you can see she is a bilateral ptosis girl, hardly any fissure is there, she can't see. So of course she will end up into dense amblyopia, or she had a head tilt. Doing a bilateral tarsofrontal sling, you can see the results are very nice. The post-op results are perfectly fine. And it can be even operated at a very late age, like this. He was a chap of 90 plus years. Some people think that at a very elderly age should not be subjected to any surgeries and whatnot. But see the comfort which this gentleman would have after the ptosis is done. Otherwise he is in a constant bro lift position, and that is also very tiring for this age group. So that relaxation can be achieved only once we do the surgery. Second myth is about Marcus gun phenomena, that it cannot be improved without doing a bilateral surgery. This we discussed in the morning session also. This is the Marcus gun jaw winking phenomena. When you move the jaw, there is a lid excursion. Though the fact is that MGP can be reduced considerably even after doing a simple ptosis surgery. Like in this lady, she is having a Marcus gun, but very nice correction and very much reduced Marcus gun phenomena post simple LPS surgery. In this again, she had Marcus gun phenomena which got reduced after doing a sling surgery. So whether you do an LPS or you do a sling, you get a benefit in Marcus gun phenomena. So there is no need to bilaterally excise the LPS and then do a bilateral sling surgery. Third myth is that a ptosis surgery leaves an ugly visible scar. Sometimes the patient come and they have a ptosis, considerable ptosis. Punjabi च कहने इन्ना ptosis है कि दूरों दिखदा किलोमीटर तो, but they will be wearing इस निशान तो नहीं रह जाएगा जेड़ा कि पता नहीं लभना भी है कि नहीं. So hardly there is a scar, and even if there is, it is very negligible. Like in this marriageable girl, you see LPS has been done where we incise the lid from about middle canthus till up to the lateral canthus. Hardly any scar. So having scar after surgeries is a myth. This area is a very forgiving area. In this girl also you see that there is, what is this noise? Okay, in this there is no scar and very good lid movement. Third myth is the patient won't be able to blink. They say that the आँख खड़ी दी खड़ी रह जाएगी जी, blink नहीं होएगा, सानू यह किया गया कि आँख blink नहीं होगी. Again, there is hardly any problem in the blink. Here no scar, and you see the blink is perfectly fine. It was done in LPS. So when you do a good LPS surgery, you hardly distort the anatomy. Of course, in sling surgeries, there could be some discrepancy in the blink rates. But if it's a bilateral sling surgery, then again, the blink is very good. This chap underwent a bilateral sling surgery. So you can see the symmetry is perfect, hardly any scars. The closure is good enough. So these all are myths which are unfortunately incorporated in the minds of the patients, and they are fearful of coming. So this video shows that even in a child of about 3 years of age, the patient can blink or forcefully close the lids. Of course, this is just 1 week post-op. This I show them stating that if within 1 week and this age group of child is able to close the lids, why not an adult or even this child after a few days? This lid lag is something which we need to counsel them about, which will be there in 100% of the cases, and then you have to tell them to move the chin down while looking down. Fifth myth is that the eye remains open while sleeping, nocturnal lag of thalamus. Of course, there is some part of nocturnal lag of thalamus which we face, especially in sling cases, but in LPS there is hardly any nocturnal lag off after about 1 to 3 months. This is one patient in which sling was done and she has a minimal nocturnal lag of thalamus, whereas the other child had no surgery done, and some people sleep with their eyes open. So nocturnal lag of thalamus may be more prominent in a normal patient or a child than in a post-operative case. But once you have touched the eye or done a surgery, सारा ध्यान उस तरफ शिफ्ट हो जाता है कि जी ये हो गया वो हो गया, उससे पहले चाहे जो मर्जी होता रहे, आधी दुनिया ने तो नोटिस ही नहीं किया होता कि टोसिस भी है. So these are the few things. This was earlier. Thank you for coming here and visiting this conference. Thank you very much.
Thanks, Raman, for this wonderful talk. You really covered everything. Just a point that in the first child, that appeared to me to be a BPESS.
First child.
So because there are bilateral epicanthal folds and there was a telecanthus. So maybe sometimes when children come with bilateral severe ptosis, you need to look at the canthal positions and the lid folds. That's one. And eponeurotic ptosis, of course, will always be in elderly. So the myth that he said that ptosis can't be operated in old age, eponeurotic ptosis is 9 out of 10 going to be in old age. Only if it's traumatic, it will be in the younger. Then for Marcus Gunn, Raman, my practice, I've seen that if you do an LPS resection, actually the Marcus Gunn worsens. So I like to disinsert the LPS on that side and put in a sling. So if you're doing it bilaterally, then maybe, because the change is going to be the same, then you may just go in, because whatever enhancement is going to happen will happen. But with sling, it does better in my hands as compared to the LPS resection.
Of course, your experience is much more than what I have. But somehow I have figured out that in most of my cases, even if I do LPS, I have found that the excursion, because earlier the eye was ptotic and it is rising to a level, for example, from a height of 5 millimeters, it's going till 11. So the excursion is 6. Once you raise it to about 8 or 9, the highest point which it can raise is 11, 12 only. So the excursion
but that
total.
LPS is much stronger now. So that innervation, again, see, the Marcus Gunn is happening because of the aberrant innervation. So once you are strengthening the muscles, the neuronal impulses are also going to increase, as happens for any squint surgery. So if you strengthen the LPS, its propensity to move more will increase. That's what I noticed. Take a mic.
Can I have the free mics, floating mics in the auditor? Switch it on, the audience mic, please.
Yeah. So basically what I do is I actually sit and spend a lot of time with the patient finding out what is their primary concern. Is it the ptosis or is it the Marcus Gunn jaw winking? If it is Marcus Gunn jaw winking, then I go ahead with the sling and excising the muscle. But if it is just specifically ptosis, because in my hands the LPSR gives much better cosmetic correction, so I go ahead with
Agreed.
that.
amount of jaw winking is the primary actually in deciding what procedure you will choose. That makes a point. Yeah.
Dr. Raman, there was a Babaji with the ptosis, aponeurotic ptosis with the, there was also squint there. So what do you prefer doing, squint first or ptosis first?
See, if the squint is sometimes intermittent, which on ptosis correction unilateral cases, sometimes because there is a poor fixation, the squint is prominent, but once you lift the lid, the squint is getting corrected. In those type of cases only, I would prefer doing a lid surgery. Otherwise, yes, by dictum, squint should be done before, because a part of ptosis is corrected by doing squint. Especially if it is a hypertropia, then there is no doubt you have to do squint first. But if it's a horizontal squint, then you can sometimes address depending upon the how much squint is, how much of the ptosis is there, what is being concerned by the patient. You have to document it well. Sometimes the patient is not aware of that subtle squint which is lying under the ptotic lid. So once you have the snaps and tell them, okay, fine, I'm going to correct it, and you already have a squint. It's not that I'm going to induce it, because after you correct the ptosis and the squint becomes prominent, the patient may say, "Ate aap teddy karti ji pehlan to theek si."
That concern is very important because we get so many patients with both squint and ptosis also together.
Perfect.
And second, last comment only, the rapid eye movement takes care of the dryness which is there with the lag ophthalmos in night.
Sorry, come again.
The rapid eye movement in night takes care of the dryness part or the exposure. So we are not that much worried about the lag ophthalmos.
Very true, but the patient's concern is कि भाई रात को आँख खुली रहेगी. So जब कोई अटक जाता है उस बात पे, तो न ऐसे कि रात को ज़्यादा इम्पोर्टेंट है देखना कि दिन में सारी रात, सारा दिन, सारी जिंदगी आँख नीचे है, वो ठीक है. रात को तो किसी ने देखना नहीं.
अटके हुए पेशेंट का कुछ नहीं कर सकते.